who had CRPS for 8 years following multiple fractures and dislocations to the left wrist, arm and shoulder requiring surgery. It was quite extensive damage. And we actually tested her body perception disturbance using the Bath CRPS body perception disturbance scale, which was developed by Jenny Lewis down at the Min. And it was very, very profound, her body perception disturbance in all 3 sessions. So basically pretty much the same, 55 out of 57, where a high score is bad body perception. And we tested her across 3 sessions. So this is spanning 3 years. And this is the sort of a diagram depicting her mental representation of her affected limb. She could really see in her mind's eye the affected limb. She didn't really have a sense of the limb being there. There was kind of a stick bone sort of there, and then where her hand should have been, it was just a blob. And here are where she's indicating her pain across the different sessions. So the reason why we were conducting a case study in this patient is that when I first saw her, she showed some very, very profound symptoms that I had never seen in a CRPS patient before. So I'm going to present a video, and your job is to pay attention to the video, and I'm going to ask you what you observed after I show it to you. So here we go.
Okay. So I want you to look at my nose, and I'm going to wiggle a finger, and tell me when you see it wiggle. Okay, so come next to me. Yeah. 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 Okay. And now I'm going to hold my fingers up. I want you to tell me which one wiggles, left, right, or both. Okay.
Left, right, 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 both, left, right, both, 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 left, right, both.
Okay, so where does she appear to have a deficit? What's she having problems with? And you can answer in the chat, or you can just speak up. If no one answers, then I'm going to have to call on Jeremy. Oh, here we go. Okay.
Yeah, something's definitely missing on the left-hand side.
Yeah. So when I wiggle the finger on her, so at the very beginning, what I was doing is I was testing her visual fields. So I was checking that her visual fields were at least symmetrical. So she could see the finger wiggles at basically the same sort of distance as I went around from her periphery. But when I did this and did single finger wiggles, she was slow to notice or to report the one that was happening on her left side, which is her affected side of space. And over the 3 testing sessions, generally when we did this sort of thing, she either didn't report single finger wiggles that happened on the left, that's what this is, or if there were 2 finger wiggles, she would just report the one on the right and not the one on the left, which is what this is here. And she very rarely, almost never, missed things on the right-hand side, so her unaffected side. So this is classic hemispatial neglect, which is something that I have a big background in prior to my days in pain. It's typically a condition that follows stroke, so brain damage, affecting the right hemisphere of the brain, where people have difficulty attending to the left side of space. In this case, we have a person with CRPS who's showing this very classic behavior that I would normally expect to see in someone who's had a stroke, but she hasn't had a stroke, she's got CRPS. So this is neglect. The other problems that she had that are relevant for my talk today is that she reported quite a lot of different problems with vision. So she told me about how she experienced double vision and a loss of peripheral vision, and that her visual acuity was deteriorating. She had to keep on going back to the optician to get new glasses quite frequently. She reported having vestibular problems, which may or may not be associated with visual deficits. And she tended to veer off to the left when she was walking. And so we actually tested her vision and found that she did indeed have impaired monocular and binocular visual acuity. So when we tested one eye at a time or both together, she had impairments. So 2020 is normal. So 2050 means that she needs to be at 20 feet away from something to see what a normal person with normal vision could see at 50 feet. So she has to be much closer in order to see it. And she also had worse than normal vision for eccentricities of 12 degrees or greater. So we tested this by showing her these kinds of circles with gaps, and she had to say whether the gap was on the left or the right or the top or the bottom. And she was fairly accurate towards the center of vision, but for eccentricities greater than 12 degrees from the center of her vision, she was significantly worse than the age-matched controls. So this patient had both neglect-like symptoms and visual problems. And these are the sort of two categories of symptoms that I'm going to talk about today, because I've now done quite a bit of research on this in understanding these different things in people with chronic pain, especially complex regional pain syndrome. But there's a couple of other pain conditions, well, some other pain conditions that I study as well. So first I'll talk about neglect in chronic pain. So why study neglect in chronic pain? Why could this be interesting and useful? So the first is because neglect has been fairly well classified in hemispatial neglect. And we know quite a lot about attention and spatial attention in hemispatial neglect. We know that, for example, it can manifest in different regions of space. So this is a diagram that shows this. It sort of summarizes this. So neglect following a stroke can manifest sort of just on the body and not affect external regions of space, or it can manifest just on external regions of space, and that could be only one of these different external regions of space or multiple. And all of these kinds of things have been really well documented in stroke patients. So understanding if this provides potential opportunity to try and understand if the sorts of things that are going on in people with CRPS are similar to what goes on in stroke patients or different. And if they're different, or actually regardless, it might provide new insights into how spatial attention works generally, just so we know something new about the brain and the mind, or it might just provide some new insights into the pain conditions. The second reason is that we have treatments for hemispatial neglect following stroke. Some of them seem to be more effective than others, but this is just a graph summarizing some data from a treatment that I've been investigating. And these are just small n studies that all showed a decrease in pain intensity in people who did this treatment. The treatment's called PRISM adaptation. So this is people with chronic complex regional pain syndrome doing a treatment that has been developed for hemispatial neglect following stroke. So if you use this treatment for the people who have neglect following stroke in people with CRPS, at least these initial studies seem to show that this was a very was quite promising for treating CRPS. And this is actually the very first study that I did in CRPS, and this is what got me going down this route. So I'm just going to show you one of the main ways that we study neglect in CRPS. So the finger wiggles is all very good, but it's a little bit difficult to control, like how big a finger wiggle do you do? How long do you how do you quantify the fact that it might take them a long time to report it versus a little time to report it? So instead we try and be more systematic and measure it in a more controlled way, but also in a more precise way. So more audience participation here. You all need to look at the cross in the middle of the square here, and you're going to see two lights, one on the left and one on the right. You need to tell me which one appears first. So get ready. So which one appeared first? Who was awake?
Left.
Left. So Jeremy's got it and everyone else is awake. Good. So if someone has an attention deficit on this left side, then they would process that left dot more slowly than the one that appeared on the right. And as a result, just say their attention deficit was quite severe, they would report those two lights as appearing at the same time because it would take them longer to process the one on the left. So what we can do is over many, many trials, we can present these lights with different amounts of time between them, and sometimes with the one on the right appearing first, for example, and we can figure out how much time needs to go between the two for the person to perceive them as being simultaneous. And that amount of time gives us an idea of how severe their attention problem is. So a little bit of offset is the small attention problem, a long offset is a larger attention problem. And also, because this task doesn't involve any sort of movement or anything like that, and they can respond just with a button press or with a word, it means it's not being contaminated by any kind of, any other sort of deficit. And I mean, even if they're pressing buttons, you can make it so that it's not being contaminated by any kind of physical limitation, because you could, for example, get them to respond with their unaffected hand. So we use this kind of task with this in this case study that I showed you a moment ago. And this is actually one of the main tasks that we use. We did lots of different conditions, and I'm not going to go into because we were sort of manipulating different aspects of how we presented this to try and test different theories. But I'm not going to go into that at the moment. What I am going to do is show you what I think is probably the most interesting finding from this case. So we have the control, age-matched control participants who showed no bias because their bias is around 0. In this way of calculating this temporal offset, a negative number means that the person is neglecting the left side. A positive number would mean the person's neglecting the right side. And as you can see, the patient who's in black is showing significant neglect of the left side, that is her affected side of space, using these kinds of tasks. And that's in the first 2 testing sessions. Then in the 3rd testing session, her attention bias completely flipped. So suddenly she's neglecting her unaffected side of space, and she's actually paying more attention to her affected side of space. So that's really confusing. Even though there has been a lot of research in people with hemispatial neglect following stroke, it's virtually never been reported that someone would have the opposite attention bias. Occasionally you might see it on 2 different kinds of tasks, but it's almost never been reported. So this is the first indication that CRPS in the neglect-like bias in CRPS is something different to in hemispatial neglect, which is, probably not surprising to you. I'm not necessarily saying that we would always expect them to be the same. What's important is her pain and her symptoms and her body representation disturbance didn't change across these sessions. She still had profound body representation disturbance in this session, this 3rd session, but her attention bias changed. So this is the first indication that attention bias or neglect-like symptoms in CRPS are different to what we see in hemispatial neglect. And this slide is basically to try and explain to you really, really quickly a whole lot of work that's been done in my lab, and just summarizing it really quickly so we can talk about some other things. Because through a lot of research in my group, mainly Monica Halisko, who did a PhD with me, and Tony ten Brink, who came over to do a postdoctoral fellowship, we tested attention bias really, really thoroughly in people with CRPS, and overall pretty much found that people with CRPS don't show any bias on these kinds of perceptual tasks. Monica also had a classic motor task that you would typically use with people with hemispatial neglect, and found the teeniest, tiniest little smidgen of a hint of a motor bias, but really overall no motor bias. So, and the other thing is that Monica did a randomized control trial of prism adaptation for CRPS and found no difference in the effects of real and sham prism adaptation on pain or CRPS severity. So what we found is actually overall, even though my very first study looking at this in a group of CRPS patients did find neglect, I would say the studies that we followed it up with, which have more tasks and more patients, found no evidence of spatial attention bias. So I actually now think that there's none of this perceptual neglect in CRPS overall as a group. And also this treatment, which is for hemispatial neglect following stroke, doesn't actually seem to help CRPS. So in that case, what is neglect in CRPS? So this is the neurobehavioral questionnaire that I'm sure many of you have used. And this has 5 items, and it's asking, well, it's about 3 different proposed concepts to do with neglect, what can be referred to as neglect-like symptoms in CRPS. So if I don't focus my attention on my painful limb, it would lie still like a dead weight. And what we tend to find is, regardless of what happens with our perceptual tasks, people with CRPS do tend to show neglect-like symptoms on this kind of questionnaire. So their self-report does show that they have this sense of neglect or detachment from their limb. And we were interested in understanding what that detachment was and understanding it a little bit more. So I think it's slightly obnoxious to present big tables to you, so sorry for that. But what I'm really presenting is this bit in red here. So we looked at all the different studies that had used this scale or report on this scale in people with CRPS, and sometimes compared to control groups. And one thing that we noticed is that actually people with other limb pain without CRPS also often report at least one of these items is true for them. And people with CRPS are usually a bit higher, not always. So for example, in this group, there's fewer people with CRPS reporting at least one item. But there's also a lot of variability across the individual items. So we were curious about whether there's actually subcomponents to this questionnaire. And so whether the neglect-like symptoms, according to this self-report, can be broken down. So one way that the original authors proposed it could be broken down was into motor and cognitive neglect-like symptoms. Does that actually pan out in the data? And this is what we found. So we did a principal components analysis. We had over 300 respondents to a survey about this neglect-like symptoms using this questionnaire. And we found that it broke down into 2 components, which are basically, the first component is motor and cognitive neglect-like symptoms, and the second is involuntary movements. So that is, there doesn't seem to be 2 separate components for motor and cognitive neglect-like symptoms. They seem to be just one component, but that is separate to involuntary movements. And, we did explore what sort of things predicted whether or not people had, were more likely to report these symptoms. So we had a mixture of people with CRPS and with other pain conditions, and we had people with upper and lower limb pain. And we found that having CRPS predicted both of these components, so being more likely to report either of these components compared to not having CRPS. The motor and cognitive neglect-like symptoms were predicted by having a painful lower limb compared to an upper limb, whereas that distinction wasn't true for involuntary movements. Both were also predicted by somatic symptoms, and involuntary movemts were predicted by depression, and motor and cognitive neglect-like symptoms were predicted by pain intensity. But quite a lot of things we found not to be significant predictors. So one is the affected side, so whether it's the left side or the right side that is affected. And that's interesting from our perspective because following stroke, neglect is much more common for the left side of space, but there's no evidence for a difference between left and right neglect in terms of whether or not they have left and right CRPS in terms of whether they report neglect-like symptoms. Also, disease duration, we always look into whether this explains neglect-like symptoms or perceptual biases any perceptual biases that we do find, and we never find any effective disease duration. What we also found is that both of these components correlated really strongly with the Bath CRPS body perception disturbance scale. Now, the Bath body perception disturbance scale does have items that are kind of about attention to the limb and awareness of the limb. So perhaps it's not surprising that they are overlapping constructs, but we just kind of confirm that, and also consistent with consistent with the idea that that there are separate components, motor and cognitive neglect correlated more strongly with the Bath CRPS body perception disturbance scale. So what do we conclude about what is neglect in CRPS? So I'd say I've come to conclude that it's more feelings of detachment and disengagement from the affected limb. So things that people can tell you about and talk about, rather than perceptual biases that you can measure in these very objective sensory tests. And it's not a sensory or visual neglect in the classic neurological sense. I think it's very telling that it's related to somatic symptoms and somatization and depersonalization. So I think there's a strong element of disownership of the limb that goes with that. And again, maybe there's a lot of you out there thinking, yeah, so that's what you would say too from your clinical impression. So people often ask, or what the relevance is for treatment in that case. And the good news is that I think really that the implications for treatment are that what is already the advised, it just reinforces what is already the advised course of treatment for people with CRPS. So these are this is a diagram from the UK guidelines for management of complex regional pain syndrome. So things like physiotherapy and occupational therapy and education, and sort of actively encouraging engagement with the limb, and psychological interventions to help people overcome whatever psychological barriers they might have about engaging with the limb. All of these things will help them address that depersonalization and loss of connection to the limb. Okay, so that is the end of the neglect part. So I'm moving over to the visual disturbances part of the talk. So just to remind you, the patient case study at the very beginning did have some visual disturbances. I've just put this here because that's I like this figure. And she's not unusual in my experience, and hopefully any of you who have experience with CRPS would agree with me that there are some people who report visual disturbances. So why could this be interesting and relevant? So one possibility is that this could be a non-somatic indicator of central sensitization. So what I mean by that is that it's an indicator of central sensitization that doesn't require you to kind of touch or manipulate or measure the physical body. And that could be relevant and interesting for lots of reasons. And one could be, for example, simply by providing a way of testing for central sensitization without actually having to touch the person, because someone with CRPS might not want you to get anywhere near them. It would even mean being able to do some things remotely. So you could measure central sensitization over the internet using some simple computer-based task, which is actually what we have done. Also, it could be relevant because visual disturbances in complex regional pain syndrome specifically could be an indication that the underlying mechanism is to do with visual conflict. So one of the hypothesized mechanisms of CRPS specifically, and some other chronic pain conditions, is that it arises because of sensory conflict. So a conflict between what the sensory outcomes of a movement and the expected or anticipated outcomes of those movements. And Candy McCabe has done a lot of work on that some of you may be familiar with. The third reason to study visual disturbances in chronic pain is simply to get a more accurate clinical picture. So someone with very complex symptoms and signs might, it might be that they have visual disturbances that really are quite bothersome to them. And maybe it won't be their primary complaint, but it could still be something that could be improved and maybe improve their quality of life. So I'm going to go through 3 studies where we've explored visual disturbances in chronic pain. The first 2 weren't primarily aimed at evaluating just visual disturbances. whereas the last one was specifically designed to investigate this idea of whether visual disturbances occur in CRPS. And actually all of these also, we tested people with fibromyalgia as well, because fibromyalgia is often reported in people, people with fibromyalgia often report visual disturbances. So we were interested in whether visual disturbances occur in people with CRPS because that was less documented, and also in documenting it in fibromyalgia and seeing if there seems to be any similarities or differences, and potentially learning something new about fibromyalgia as well. So the first was a broad online survey in which we asked people with CRPS, fibromyalgia and other pain conditions to just tell us if they experienced certain symptoms in their body or in their vision or their hearing that weren't necessarily part of the diagnostic criteria. So we gave them a big long list, and we also had the opportunity for them to give us other examples that we hadn't included. And we categorized these as you can see here, but I'm going to focus on the vision and hearing category here. So these are the items that were in the vision and hearing category. So they had to say just simply whether or not they experienced these things since their condition onset, or if they're pain-free controls, it was just, have you experienced an increase in any of these things over the last 2 years? You can actually go and find the individual item data if you like. It's part of the supplementary material to this paper. So the red here are the people with CRPS, and the blue are people with fibromyalgia. Purple are people with fibromyalgia and CRPS, which is, it's not very common that you can report on people who have those overlapping conditions. So we had sort of a bit of a unique experience being able to look at that as a separate group. And what you can see is that people with CRPS don't report these vision and hearing symptoms any more often than people with other pain conditions or pain-free controls, but people with fibromyalgia do. So people with fibromyalgia report it more often than the other groups. That's the blue. And the purple are people with fibromyalgia and CRPS, as I said. So probably we don't know for sure, but probably they're reporting it these more often, probably because of the fibromyalgia rather than the CRPS, although, as I said, we don't know for sure. Okay, so that's just people saying, here are some things that I'm experiencing in my life. But the other thing that we asked is about things that actually cause them pain or discomfort or distress or increase their pain, or like intensified their pain. So I tried to do a sort of visual summary here, but it will take a bit of talking through and hopefully it would all make sense. So what I have here, I've broken the groups into the CRPS group and the fibromyalgia group and compared them to the pain-free controls and the other pain. So where it's orange is where there's a significant difference. So focusing on these 9 squares here first, what this tells us is that people with CRPS more often report that bright lights, flashing lights, and high contrast images cause them pain, discomfort, or distress or whatever it is, compared to pain-free controls. So you can see that there's some squares where there's no difference, but overall, just if you take it as a general impression, people with CRPS generally report that these things are more likely to cause them pain, discomfort, and distress compared to pain-free controls. But compared to people with other pain, not really. So people with CRPS don't really report that these things cause them pain, discomfort, or distress more than people with other pain. However, we could say that maybe it does intensify their pain. People with CRPS, these things intensify their pain more than people with other pain, especially bright lights and flashing lights. In people with fibromyalgia, really they're reporting that these types of stimuli, these types of visual stimuli, really do give them pain, discomfort, and distress more than pain-free controls or people with other pain conditions. And it also really intensifies their pain more than people with other pain conditions as well. So what we're seeing is that both people with CRPS and fibromyalgia are reporting that these kinds of stimuli give them pain, discomfort, and distress. But it's really the people with fibromyalgia who are reporting that even more than people with other pain conditions. And yeah, someone has asked, what about the people with CRPS and fibromyalgia? They tend to show the same as the people with fibromyalgia by itself. And we do have a little section where we summarize the findings for this group that you can find in the paper, but they tend to show basically whatever people with CRPS, they sort of show the worst of both worlds, but really it's more that they show the same sorts of patterns as people with fibromyalgia. Okay, so this is showing that people with fibromyalgia do show more visual discomfort and visual symptoms and things in their environment are causing them visual pain, maybe to a small extent people with CRPS, but people with CRPS aren't showing that many differences to people with other pain conditions. So this is just a self-report online survey. So in the next study, we were actually aiming to measure these things ourselves, because maybe when we actually go and measure visual symptoms, we'll find something different to what people are reporting in their own experience. So this is part of a lab-based study that Tony did, and this was more interested in the neglect side of things, but as part of that, we tested people's vision as well. And she found that in her group of upper limb CRPS patients, they had their visual acuity in their right eye was lower than the pain and pain-free control groups, but there was no difference for their left eye. So there's worse visual acuity in the right eye, but not the left eye. And that's regardless of whether the person had left CRPS or right CRPS. But she found no changes in the peripheral vision of the people with CRPS overall. So this is contrasting with our case study who showed peripheral vision loss. So there's a little bit of a change here. It's a bit hard to interpret because it's to do with the right eye rather than the eye on the affected versus unaffected side of space. But there is a little bit of evidence here that we have decreased visual acuity in people with CRPS. So this leads me to the study where we actually tried to measure these kinds of things systematically. So this was an online study where we really wanted to find out whether people with CRPS or fibromyalgia showed problems with vision, especially visual sensitivity, compared to people with other pain or people without pain. So we did this a few ways. So one way is that we administered 2 scales that are standardized scales of visual sensitivity. So these were developed for people with migraine, and we actually validated these scales for other chronic pain conditions too. So they are valid for testing people with broader chronic pain. And so these are just, again, asking people, do they feel sorts of discomfort and things like that in their everyday life? And we also used some experimental measures of visual discomfort. So again, this is a task called the pattern glare test that was used to developed to measure visual discomfort in migraine. And hopefully some of you will already be looking at this and going, "Ugh." So this high spatial frequency image, that means like little stripes, causes most people some degree of visual weirdness, and maybe if you are unfortunate enough to suffer migraines, you might find it also causing you visual discomfort, so please look away. This one might look a little bit weird, but this shouldn't cause any kind of visual discomfort. So that's from the pattern glare test, and then we added this one because we thought it would be useful to have a control image that had no stripes, and this is kind of lower contrast as well. And so they were shown these images one at a time, and they were asked if the image decreased or increased pain, discomfort, or distress. So they were asked separately about pain, discomfort, or distress, but I'm not going to sort of go into all of the data because it's a bit too much. So in people with migraine, this pattern causes discomfort and pain and visual distortions. And it's thought to be because this kind of pattern is processed in primary visual cortex in an inefficient way. So it's kind of encoded across primary visual cortex in a inefficient way, which creates excessive metabolic demand. So basically, our brain and our blood supply has to work harder when we're processing these kinds of images, and that seems to be what what causes migraine and that kind of discomfort in people with migraine. We also wanted to replicate the study that's been done by Jane Hall and her colleagues when Jane was at the Min, where they were looking at, they were trying to test the effect, well, they did test the effect of visual conflict in people with CRPS. And so these kinds of reversing images, so this is the necker cube, the duck rabbit. So maybe you think this is a duck, but it's actually a rabbit, or is it a duck? Maybe it's a rabbit. These kinds of visual conflicts, they were testing whether visual conflicts increase pain in people with CRPS, and they did find support for that. So we wanted to replicate this. And so we showed these 3 images one at a time and asked whether the image increased or decreased pain, discomfort, or distress. The other reason why we did these different types of image types is these images here with the stripes really are testing low level vision. So very, very basic, very sort of the first sort of visual processing steps. Whereas here we're really testing later vision. So it takes a little bit more visual processing to get to sort of interpreting the necker cube and the duck rabbit. So we wanted to know whether there were any differences between lower level visual processing and higher level visual processing in the people with chronic pain. So we had people with CRPS, fibromyalgia, other pain conditions, and no pain. And what you can see here is these are the results of the questionnaire measures. People in all of the pain conditions, in the 3 different pain conditions, reported more everyday visual discomfort on these questionnaire measures compared to people without pain. And the results were very similar for the 2 questionnaires. And really, it's the people with fibromyalgia who are reporting significantly more everyday pain compared to the other 2 groups. So people with CRPS don't report more everyday visual pain compared to people with other pain, but people with fibromyalgia do. So something about fibromyalgia that is that seems to be associated with greater visual discomfort in terms of everyday life. On this test of low-level vision, what we found is that people with CRPS or fibromyalgia reported an increase in pain while looking at any 3 of these images compared to the other 2 groups. So people with CRPS or fibromyalgia reported pain to any of these to a greater extent than people with other pain or with no pain. And similarly, this square here, which is supposed to be a basic simple square doing nothing, this one, they actually also reported greater pain. So this is consistent with this idea that it's really lower level visual processing that is causing visual discomfort in people with CRPS and fibromyalgia. We had a very interesting finding with this necker cube, which is that the people with other pain actually reported a relative decrease in pain while watching this. The only interpretation we have of this is that this somehow distracted them because you're sort of watching the necker cube flip back and forward in terms of its percept. So maybe it sort of distracted them a little bit from their pain, and the people with CRPS or fibromyalgia didn't benefit from that distraction. And another interesting finding is that there was no group difference in this, in the pain or discomfort caused by this duck rabbit. So this duck rabbit is something that requires it's involved in visual processing at a much later stage in visual processing. So you have to actually process this pretty well to sort of go duck, rabbit, whatever. You have to sort of associate it with the identity duck. There's a lot more that has to go into it. So it seems like really the differences that we're seeing are really to do with lower level visual processing. The other thing that's interesting is that the light and pattern sensitivity in daily life, that is the questionnaire measures, correlated with the pain reported for all of these 4 images. So the everyday life discomfort does actually seem to be to some extent related to the discomfort that people reported when they saw these individual images. So we wanted to, we're thinking about all of this, and one thing we wanted to think about is actually, are people just reporting pain because they are people with chronic pain and we're telling them you might experience pain when you see these images, because we kind of had to tell them that ethically. And it can't be that, because they're not reporting more pain for this image. So if it was just a kind of a hypervigilance or a pain anticipation, then you'd expect to see it for all of the images, but they're only showing it for some of them. What it seems to be is, what seems to be going on is this idea that there's a hyperactive nervous system. So that is central sensitization, which is leading to excessive metabolic demand, like what has previously been described in migraine. The good news about that is that you can use precision tinted lenses to help people with migraine related visual discomfort. So perhaps there is an opportunity to try that with people with fibromyalgia and CRPS as well. So people who have those other pain conditions who do report that they have visual discomfort might benefit to some extent from these kinds of lenses. Won't necessarily help their other pain symptoms, but it will at least potentially reduce the visual discomfort that they experience, and that could do things like help them rest better and just generally enjoy their day-to-day life a little bit more. So to conclude, I guess the things to take away from this talk are that most people with chronic CRPS report one or more problems with thinking about attending to, using or engaging with their affected limb. And self-reported neglect is related to more intense pain, somatic symptoms, and possibly psychological factors, although causal links can't be inferred from the current data. Generally, we found that visual disturbance in fibromyalgia is greater than in CRPS, although it does seem to be present in CRPS. And also that visual disturbance in fibromyalgia or CRPS may be a non-somatic sign of central sensitization. And then the last slide is just my acknowledgements. So you've already seen these very happy faces, which is Monica, who did her PhD with me, Tony, who did a research fellowship with me. I really just benefited from her bringing her own money. Axel was also a PhD student in my lab who collaborated with basically all of the studies that I've presented to you, as well as Michael Prue, who's a collaborator in Bath. And these are all clinical collaborators who have helped, especially with the randomized control trial. So that's the end of my talk. So are there any more questions? Please make them not too hard.
Thank you very much, Janet. That was really interesting. So I'm going to keep an eye on the chat for any questions that's coming up. And as I'm the chair, I get to sneakily get one in first. And it's a little bit about the data on neglect and CRPS. So we've seen the depersonalization and the kind of sense of neglect, of loss of ownership of a limb. Sometimes in CRPS, we see something which is closer to a really fierce aversion and disgust towards a limb. I suppose I wondered if you had any thoughts about that, but I wondered if anything like that was seen in visual neglect. Does the parallel go back in that direction?
So thanks, that's a good question. So people with hemispatial neglect following stroke often can have that kind of disgust. It's referred to as mesoplegia when it happens. This aversion to in this case, it would be the limb on the opposite side of space to their lesion. And it's considered to be a separate syndrome. So it is often associated with hemispatial neglect. It sort of commonly follows a right hemisphere lesion when you do see it. And most people with mesoplegia would have hemispatial neglect, but they are definitely two different syndromes. So the sorts of disgust and aversion that people with CRPS can have to their affected limb is definitely seen in people with stroke, but considered to be a separate condition. And that's kind of where, again, I think that a lot of what is seen as maybe neglect-like in CRPS may actually be more to do with body representation.
That's great, thank you. And we've just got a comment coming through on the chat there that perhaps the tinted glasses idea may well be a good one.
Yeah, that's great to hear, Chantel. Thank you. I should also point out that that's not my idea. I don't want to take credit for the tinted glasses.
So just from Jen there, do we see any visual disturbances in acute pain conditions?
So I don't myself have a lot of experience in seeing acute pain. So maybe someone else who is here will be able to comment on that. The only thing I can mention is I don't know about visual disturbances, but in terms of neglect or body representation disturbances, people who come and do our research often say that retrospectively, they felt this body representation disturbance immediately after their injury. But I don't remember anyone ever saying, as soon as I had my injury, I noticed my vision went blurry. So I don't know.
Has anybody tried to look at this with unilateral experimentally induced pain? So has anybody looked at whether if you just zap or freeze somebody's left hand, that produces any kind of spatial or visual or perceptual disturbance?
Yes, people have done it with spatial disturbances and it doesn't have an impact. It's pretty hard to, I mean, you can, but it is pretty hard to manipulate attention to that extent in healthy people in a sort of temporary way. What happens if you zap someone's hand is that they will pay more attention to that side, because obviously pain is attention grabbing normally. And the other visual disturbances, I don't think so. My guess is that the visual disturbances that we're interested in, so sensitivity to bright lights and things like that, would really only emerge in the more, as things become more chronic. If that is the case, then that would be, again, consistent with the idea of central sensitization.
Thank you. Has anybody got any more questions? Otherwise, I'll just keep asking them. But very, very interested to hear from many of you in the chat. Okay, stuff it. I'll go again then. Just take it back to the beginning of this whole narrative where it looked like there were individuals with really unusual sort of spatial representations, and then the group studies showed not so. I mean, are you still convinced that is the group data washing out individuals who are unusual? Do you think there are a minority of people with something pretty wild going on? It's not typical, but it's there for particular individuals.
Well, yeah, I've seen, first of all, my very first case study patient responded really strongly to prism adaptation. And also this case that we reported with the attention bias that I showed in the video clearly had something very striking going on. So there do seem to be these very rare individual cases where there are some really striking neuropsychological changes, and also reported in the literature, again, some work from the Mineral Hospital in Bath showing things like where people are copying pictures but upside down and things like that. Really things that you would only normally see after a stroke otherwise. So there do seem to be isolated cases. In terms of our group data, we analysed our group data to death to try and see if there was any evidence of a subgroup who did have an attention bias. So, for example, I have spare slides. So this is just one of our studies where we had 5 different tasks, but this is 4 of them. You don't need to know what the tasks are, but the further over here, the dot is the more the attention bias away from the affected limb. The further over here, the dot is the more the attention bias towards the affected limb. And red is people with CRPS and blue is people with just healthy controls. So what you can see is we have a CRPS patient with a very, what looks like neglect of their affected side, but we do have these patients over here who seem to have hyperattention to the affected side. If they really did have a strong neglect, like pattern, then you would expect this to be consistent across the 4 tasks, and they aren't. So this person here shows a neglect on this task, but it's not really coming out anywhere else. So we can't really conclude that that there's a subgroup basically. And we've looked at it in a few other ways as well, but we haven't found any evidence of a subgroup. And actually, I have another slide here. So this is showing that this is looking at, on one of the tests, whether the performance is consistent over time on the one test. So these are people who've been tested on 4 different occasions, and it's correlating their performance across the different tasks. And what's really interesting actually is that the correlation is worse when you correlate the first testing session with all the other sessions. But when you correlate the second testing session with the third, or the third with the fourth, you actually do get a strong correlation. So this is kind of interesting, because what this might tell us is that, most of these studies only really use one testing session. but it's possible that maybe because it's a new environment and there's lots of weird stuff going on and there's lots of instructions to understand, that we're actually not getting the most representative performance out of people in that one testing session. So maybe what you actually need to do is test people on multiple sessions to actually get more consistent data. But even though there's correlations, those correlations are still overall not showing any evidence of a bias. So.
Okay. Thank you. You can read the question that's just come through there about whether any of this is in any way prognostic or a risk indicator.
I mean, I'm really now just channeling all of my clinical colleagues, which is to just really encourage anyone who has an injury to engage with that limb as much as possible from as early as possible, and to, if there are any inklings that that the person's showing anything that you might cause any kind of alarm to you, like they're complaining that their cast is too tight or painful, then to do something about it immediately. So change their cast and just have as early as possible an intervention as you can. So nothing new, I'm afraid.
Okay, well, we are approaching the hour of 5, where we traditionally bring things to a close. Has anybody got any last questions for Janet? All right, well, I think then we will call it a wrap, and thank you very much for summarizing what is quite a formidable amount of data and a huge number of experiments, obviously done in a dedicated way over many years. So that's just really great for us to be able to get a top line summary of that body of work. It's much appreciated. So
thank you very much,
Janet.
I should apologize for sending so much your way. So I hope it was understandable. But
it was great. Okay, so I'll bring this to a close. I will send an email to all the attendees and enclose a link with the recording as well. And just to let you guys know, we have got a Christmas pain forum coming up. So we'll obviously inform everybody, but on December the 6th at 4 o'clock, we have Dr. Andreas Goebel talking here from the Walton Center and at the Pain Research Institute at Liverpool University. And he is going to be talking on functional autoantibodies in symptom-based disorders, time to act, which sounds like Andreas thinks there's some definite clinical potential in what he's looking at. So that will be a great one. So we look forward to seeing you there, I hope. Thanks once again to Janet, and we will call it a wrap for this evening. Thank you. Bye-bye.